Thank you and good morning. I'm Nancy and this is Meryl, Nurse of the Year. She too has paparazzi at her door. Or not, yes. So we're from the MARTA Refugee Service, which is based in Brisbane, and Meryl did a presentation yesterday in regards to refugee nurses and their role. And today we're going to focus a little bit more on our service, what we do, and some of the technological options that we've taken to be able to store and share information with appropriate people. So this morning we had such a great presentation with great dreams about Amazon dropping off medication and things like that. And all the meanwhile, in primary care, we find that our technology is not so favourably accessible, I guess you could say. As a co-location model, we really struggle with the fact that as MARTA refugee staff, we are co-located in basic GP practices. So we use a variety of software, we use other people's computers, and these things make technology a little, I guess, challenging at some points in our patient's journey and our experiences as nurses. So this is what our talk is on today. So a little bit more about what we do in our model of care. Basically, a refugee will arrive into Brisbane and enter the world of health, hopefully within the first 28 days of their arrival. So these are people that have arrived on a confirmed refugee visa. They have full access to Medicare, Centrelink payments coming in. They start their English lessons, assistance to find housing, and hopefully a great settlement agency that will support them through all of those things. In the picture of healthcare, with a refugee health assessment being completed in the first 28 days of arrival, we then are looking forward to dealing with any medical needs they may have, referrals that might need to be made, and the nurse can continue that journey with that patient for 6 months or more if required. So for the Medicare item number focused of those, in the 700s, 707 is a full refugee health assessment, and that can include full psychosocial assessment. I made some notes here about how I sort of do that. Yeah, so looking back at the journey that the patient or the client or their family has had to get to Australia, we know that refugees may come from the Middle East, where they've maybe just been displaced for 5 or 10 years, compared to a refugee who's been displaced for 30 years that might have come out of Africa. So their journeys are varying in experience and in the time that they have been lacking in being able to access quality healthcare. Education history, work history, that all plays a role in what level of health literacy we're looking towards. Any paediatric information in regards to the development of children, their behaviours, and then settlement needs. Do they sleep well? Do they have access to food that they are willing to eat, and not just snack on Tim Tams, which one of my families was quite happy about. And then we sort of, with all this information, construct a plan that will help the GP service move forward in being able to assist this family as their primary care doctor for hopefully an extended amount of time. So immunisation catch-up is a big one for us, a general pathology screen, and then some basic referrals for oral health, for TB screening, and that's pretty much the perfect picture. You can add on to that things like child health, any other medical ailments they might have that need specialist intervention. Those sorts of things can start to be developed in that refugee health assessment. So this generally plays out over 1 to 2 visits for us at the very beginning, creating this sort of plan and shaping it. So you're looking at a couple of hours with the patient, working with the GP service at the same time to start to build that case. So in doing all of this, we established that there's some complexities in that. The refugee nurse is not a permanent member of staff at that GP practice. That means that I may visit 5 practices in a week, and so I have 5 little caseloads building one big caseload for myself, but I cannot access data on Thursday in one GP practice about a client I saw on Monday at a different GP practice. That data it belongs to the patient and it belongs to the practice. So if the TB service ring me on Thursday as the referrer and say, well, can you tell me the last date that Mohammed had his last MMR, I can't access that. So this creates I guess, a tedious situation in trying to help this process, but at the same minute, sort of hindering the streamline that we'd like to create. We also have the fact that some practices we don't visit every week. So not only can I not tell you when Mohammed had his last MMR, but I might not be back there for a month, so I can't tell you next week either, basically. If someone's entered it to AIR, yes, but this is just an example, yes. But the TB service will not go on to AIR, which is an interesting point. Anyway, that's for another talk. So lots of challenges given that GP services are private businesses and of course don't share information currently, although we are looking towards My Health Record, but that's another story for itself as well. So knowing these things, we're completely aware of the fact that we're creating, I guess, a fragmented delivery of care. We totally believe that the refugee nurse is assisting in the situation, but it does make it a little tricky. We are also aware of the fact that it is the patient's information, that it is private and confidential, and no, you can't upload it to Google Docs. You know, we can't use ways and means of storing information like you or I might. I have all of my life on a USB. If I lose the USB, I lose my life, which is my decision because that's how I've decided to store that information. If I have a spreadsheet with all of my patients' details on it, I can't have that on that USB. So very simple techniques that we have used to solve our own problems can't necessarily be used in a workspace that involves patients per se. So what we looked at was how we could go ahead and in fact use that spreadsheet but keep it confidential. So we are very proud of the fact that Excel is one of our, I guess, main contributors to our organisation. We do use a very simple spreadsheet that I made on a Monday morning a couple of years ago and has developed over some time. And then with the help of our service, Marta Health, we took some registration, I guess, in a platform, cloud sharing platform called ShareFile. Not sure if you've heard of that, but it's a basic sharefile.com. However, it offers the level of privacy and confidentiality that our health service were happy for, and we obviously have a subscription to utilise that. It does mean that we can log into any computer and access that because it is stored in their magic safe cloud. So using a spreadsheet stored in a cloud that we can access everywhere, but is not as simple as a Google Docs type situation, we move forward in tracking some data. So looking at refugee health assessments when they're completed, catch-up vaccines and the schedule of how that progresses, because we know we see patients 3 to 4 times to complete those. TB referrals, dental referrals. A big one for us at the moment is gender health checks and trying to ensure that our patients are educated and offered cervical screens. In addition to that, child health referrals, optometry, all of that information can go into that spreadsheet. And whilst it might not be everything that is in the note you've made in Medical Director or Best Practice, it is certainly enough for you to be able to track a journey and assist that patient in the meantime. So in having created that platform, we then were using that in some of our practices that we visit regularly. And what we've done is look at how effective we are in practices where we use that regularly versus practices that we maybe don't use it or don't visit as often to update that data. So now Meryl's going to look at our evaluation of that.
Okay, so as Nancy's mentioned, she's not always in the same practice every day, and in fact I'm the only part-time member of our service. We have about 6 or 7 other nurses who are all part-time, so it may not even be the same nurse. We like to try and keep the same nurse in each practice, but that doesn't always work out, so it's actually often different nurses in different practices. So sharing the information and making sure that it transfers seamlessly is really important. But we also wanted to know, actually, was there a difference between, or did the intervention work? Did this tracking mechanism enable us to deliver the same quality of care across practices where we were regularly compared with practices where we just had an intermittent presence? So what we did was we compared data from the practice where Nancy works all of the time, regularly every week, with 3 practices where nurses just go in on an as-needed basis. So we looked at 122 out of, we have around 850 newly arrived refugees coming to the Brisbane area every year, all of whom are referred to our service. So it's about 14% of all the new arrivals in that 12-month period. And we compared all of the patients who went to the practice where Nancy works with patients, a similar number of patients, but spread across 3 practices where we go intermittently. So you can see the practice where Nancy works regularly, 93.5% of all of the patients that Nancy sees there, so across the lifespan, completed their catch-up immunisations. Everybody had an oral health and a TB referral, and 25% of the women had had a pap smear. That's just basically because Nancy isn't doing the pap smears, otherwise it would be 100%. And it took, on average, about 165.8 days to complete that management plan. And then we compared that with the other, another 3 practices. So you can see there is some variation there. And interestingly, so the practice at the bottom there, where it took less time to complete the management plan, scored very poorly on gender-based health checks. Again, so possibly because the nurse wasn't there all the time to kind of remind people. But the reason why that figure is shorter is because a number of children arriving into that practice had come from the Middle East, where generally vaccination coverage was very high previously. So they actually arrived with very high rates, or very well vaccinated on arrival. We also had 2 patients lost to follow-up in that group as well. So there are some limitations of both the audit and the intervention. So basically, the mean time to completion in intermittent practices was lower than the ones at regular practices because of the children arriving with almost complete immunisation, which brought down the overall average, so that's a bit misleading. It's also reliant on the refugee health nurses actually completing the spreadsheet as part of their regular workflow. Some are more technologically savvy than others. The other really big restricting factor is whether or not the practice that you're working in has Excel. So to download something from ShareFile, you have to have the application on the computer that you're working on in the practice. So if you don't have Word in the practice, you can't download a Word file. If you don't have Excel, you can't download an Excel file. Nancy has carted an extra laptop around with her to some of these practices because she's very dedicated like that and likes technology and her spreadsheet, but she's probably in a minority there. It's a bit fiddly. Some of our other nurses might not cope with that. So the benefits are obviously that it does allow lots of different nurses working across lots of different sites to ensure that everybody gets the same coordinated and equitable service, which is what we want, the best for everybody. It also provides a simple, secure handover method for nurses working at different practices. The spreadsheet has the same fields in it as the spreadsheet we use to record nursing hours, which helps us to understand the workload of each clinic and manage our future service planning. So from here, we want to continue to use ShareFile and the tracking spreadsheet. both to ensure quality care and monitor our performance as a service. We're going to continue to review sort of any clinical guidelines to make sure that the minimum standards that we've set are still relevant and change them if we need to. We may look at actually giving nurses in the practices access to the tracking spreadsheets, because if we're not there all the time, well, maybe they can use them as well. So could this be applied elsewhere? Well, you know, really, it's a good idea to ensure that minimum standards based on best practice are agreed. You know, what benchmarks do you want your patients to achieve, and might work well for patients, other complex patients with a kind of expected journey. So possibly those with a chronic disease management plan. And also ShareFile is, you know, stable, secure platform that complies certainly with hospital privacy policies. And it's very, very easy to use, even for those of our sort of slightly more technologically challenged nurses. So it is a way that we have managed to free ourselves of fax machines, which I think is a win for everybody, because let's get out of the 80s, people. It's time. Thank you very much.